So, amidst the buzz that surrounds our upcoming election, the other topic that seems to dominate current discussions is AI. Often portrayed as a new phenomenon, those of us in eye health know that the uniqueness of the eye and the retina have lended to AI being integral to ophthalmic research and care for some time now. Today, we're going to dive deeper into this topic. First, with a leveling discussion on AI in healthcare, which will be followed by more specific conversations about eye health and AI. It might seem counterintuitive to link artificial intelligence and patient centricity, but our keynote guests today will explain why these concepts must be fundamentally intertwined. Joining us for a fireside chat titled The Human Side of AI are our friends Randy Rutta, CEO of the National Health Council, and Dr. Brian Anderson, CEO of the Coalition for Health AI, or CHAI. Now I'd like to hand it off to Randy to start the discussion.
Thanks so much, Jeff. It's a real pleasure for me to join the eye health community today to focus on that critical and very fast evolving issue of artificial intelligence, or AI, as it applies to the health sector. We're very fortunate to have your visionary leadership, Jeff, as chair of our National Health Council Board of Directors in all things, of course, including championing our efforts to inform and engage the patient community in the development and use of AI to benefit patients and patient health. We're truly fortunate to have Dr. Brian Anderson, founder and CEO of the Coalition for Health AI, with us today to enhance our understanding and role in shaping AI use across the health ecosystem. Now, the National Health Council is honored to be a founding member of CHAI, where we're actively promoting extensive, early, and meaningful patient engagement in all aspects of CHAI's mission and work. And as Jeff said, I am the CEO of the National Health Council. That's a membership organization composed of 180 national organizations advocating for patients to have a voice in decisions affecting their health. The majority of our members are patient groups, such as Prevent Blindness, as well as provider, research, academic organizations, biopharma, medical device and technology companies, insurers, employers, and others who are all part of that patient-related movement to make sure that patients have access to the care that they need when they need it, and that care continues to evolve to meet their needs. For more than 100 years, the National Health Council has supported convening and consensus building on policy and practice issues affecting patients and family caregivers. And navigating AI is a top priority for the NHC currently to assure that patients and patient organizations are informed and actively shaping the use of AI in all aspects of patient health. This session is intended to enhance our collective awareness, energize and engage the eye health community as a leading stakeholder in the role of AI now and in the future. And among our priorities for this journey, we specifically aim to assure that the development and use of AI in health innovation, diagnosis, treatment, management, and tools supporting patients are informed by patients at every step. As we discuss AI with Dr. Anderson, please reflect on AI's potential risks and rewards relating to your organization's priorities for patient health and strategies for organizational excellence. For example, at the NHC, we're considering some of the following issues as we engage in this conversation. Assuring diverse patient representation across social drivers of health and background, including race, ethnicity, geography, age, and health status, particularly those with chronic conditions, multiple chronic conditions, complex conditions. All we want to assure is that those voices, those perspectives are taken into consideration as we discuss AI. We're also very focused on improving health data to close gaps and eliminate bias and inaccuracies and misinformation that we know exists today, and it's harmful to patients. And we certainly don't want that to continue, which would only undermine the ability of the algorithms that then are used in AI models and tools to be diminished if we don't address these gaps as they exist in the current health data system. promoting training and education to support all stakeholders in understanding AI, including compensating patients for their time, expertise, associated costs for travel, meals, lodging, childcare, even personal care. These are the kinds of supports that we know CHI is committed to, as well as we are committed to ensuring that as the entire AI sector moves forward, they have patients at the table and they recognize that some of that participation may need a little extra support. That's certainly true in the case of accessibility, making sure that the accommodations are thought of in advance and there for patients to be the full participants and bring all of their knowledge forward in the decisions that are made. We recognize the importance of engaging patients, caregivers, care providers across the health ecosystem in diverse settings, including primary care, cultural centers, federally qualified health centers, and other community institutions that are serving patients. And we suggest that we need to reach patient community where it is via channels that are available and culturally appropriate, be they materials, traditional or social media, and certainly engage those trusted experts and trusted sources as we pursue this journey together. And lastly, but importantly, the goal of patient-centric AI that improves patient health relies on direct, diverse, and meaningful patient engagement that is initiated as early as possible in any process. And our mantra of nothing about us without us is highly appropriate in this context. I say to anyone involved in the AI community, and I have the opportunity to do this often, it is never too soon to include patients in the conversations that will lead to understanding and then advancing AI as it directly relates to patients and patient health. So with all that said, let me get started by introducing Dr. Brian Anderson to you. And Brian, if you're okay, let me thank you for being with us and maybe just ask you to kind of help everyone get on the same page. So, as we think about AI and we try to understand what that is and where it might be headed, could you just define that term in a way that we might all understand? What is artificial intelligence or AI? What isn't it? And why is it so important in this healthcare conversation?
Great questions, Randy. And first, just let me say thank you so much for having me here at this conference. Central to the vision for the Coalition for Health AI, as it is to NHC, it is to all of us that are, dialed into this conference, ensuring that the voice of patients is heard and central to how models are trained, AI models are trained, how AI models are deployed and maintained is critical. We need to have patient voices. So what is AI? What is artificial intelligence? The definition that I like to use, a fairly simple one, and it probably misses a few nuances, but I like it. And so let me start with that and we can dig into it. Artificial intelligence is the science or art, depending on how you look at it, of making machines, computers, that can think and act in ways that you or I traditionally might reserve for humans. So it's able to, ideally reason and learn. There's this concept within artificial intelligence called machine learning, where you have models or programs that evolve over time, get smarter, as it were, as you and I think about intelligence, can do math better, or can write essays in a more nuanced and learned way. These kinds of models are traditionally in a subsector of artificial intelligence that we call machine learning. And it's really in that space, in the machine learning space, that we've seen so much of the excitement recently because of the capabilities, the emergent capabilities, really, when you have convolutional neural nets and different kinds of approaches to machine learning, like deep learning and other terms that folks may have heard, that really have unlocked that, again, that part of the definition of AI, which is making machines that can do things that you or I might think, only a human being can, a wise person can. What AI is not is, the kinds of programs that are out there that are what I would call like very rigid if then sort of logic programs, or um, a math program behind the scenes that is able to do some kind of advanced calculation. Those traditionally aren't thought of as AI. And it's really in the machine learning space where we've seen recently some of the incredible, frankly, breathtaking advances in how AI has begun to be used in different sectors of our economy. Certainly within the health space, how it's enabled uh, physicians, nurses, to ideally, hopefully, be able to deliver better care. Part of the challenge in AI that I'm often asked is, well, how do you explain it? How does it do these things that, we're seeing it do? When we're being honest with ourselves, the answer truly for some of these very large transformers that these models are based off of, like ChatGPT or Gemini, is we don't really know exactly how these models do the things they do, which is, again, coming back to how you and I learn and how you and I come to an answer. It's hard to exactly explain why it is we do the things we do or how it is we have the intelligence that we have. It, often involves a lot of education over the years, reading lots of books and things like that. That's sort of the space that AI is in right now that's gotten a lot of people excited, and principally where it's really important to have a diverse set of voices to ensure that we're building AI that's going to ultimately serve all of us.
Well, that's really helpful, Brian, to hear you kind of explain it in that way because it can feel pretty daunting. And as you mentioned, there's so much attention right now about the potential for generative AI, some of those new uses and applications that are literally evolving every day. And yet, I've heard it said that the term AI, has been around since 1956. We as patients and just people in society have started to have our lives touched by more rudimentary aspects of AI, as you mentioned, that just organize data or help us move through a process. But, I think this conversation now is so well timed for us to contribute to things that could be revolutionary. And I think eye health is a great example of an area of health that has already seen great strides and could move forward. As I mentioned earlier, we're thrilled at the National Health Council and our membership to be partnering with CHAI. Your leadership and everyone I've met through the CHAI organization is fantastic. Could you talk to us a little bit more about kind of its origins and what CHAI aims to accomplish? I think people would be interested.
Yeah, no, thank you for that, Randy. So 3 years ago, in the middle of the pandemic, a number of us, I think, I say all of us, probably really began to appreciate what we as a society can accomplish when we come together, when we put aside, the inherent competitiveness oftentimes that exists between organizations to focus on at the time, the pandemic. And it was in that time that we also asked, well, is there something more that we can be doing? Something that we should also be focusing on that is going to be very consequential in the near term. And so we began asking and looking at artificial intelligence and machine learning. And it was a very basic question, which is, do we have consensus on what responsible, trustworthy, ethical AI looks like at a technical level that would inform a developer, a deployer, a maintainer of AI? If you think about the life cycle of a model from its development by a software engineer to taking that model and deploying it, maybe it's at an ophthalmologist's office in a health system, and then how that model is maintained and monitored over time. Do we have technical consensus about what the good practice is for AI in those spaces? And the answer that we found was no, there's not. And that's been the vision behind CHAI's mission ever since we started.
Right.
If our mission and our desire and our hope in our community is to enable AI that can serve all of us, we need to be able to have the kinds of specificity about what that actually looks like, how we actually get there at a technical level. Because fundamentally, this is about building machines on a computer system or a big array And having the technical specificity on what good looks like is really critical in that. And so that's what Chai has been focused on is how do we bring together all of the stakeholders that are needed to ensure that we have everyone's voices in those spaces that I talked about of a model's life cycle to ensure that we're doing that ethically, that we're doing that responsibly. I think one of the first things that we realized right at the beginning is there's a trust problem with AI. And it's not just in health, it's certainly accentuated in health. People don't trust AI,
Right.
but it's across all sectors. And I think our hypothesis in Chai is people should things that they can't explain, or things that they don't fully understand, or things that they don't have a voice in that has consequence on them. To your point about nothing about us without us, that is the front and center issue in so much of how AI is developed and deployed is that there are vast parts of our society that are not part of those conversations. And so Chai has very intentionally built a community. I believe it's the largest health AI coalition on the planet. There's over 2,500 organizations. All of the members from NHC are part of it. And if AI, at its very essence, are programs that are trained on our histories, you and I have talked about this, Randy.
Mm-hmm.
We, I think, would all agree that ensuring that AI has the kind of balance and values that don't just reinforce our histories, but can help lead us towards a better future will require voices that haven't had the same power to be part of those conversations, and namely patient voices.
Right.
So much as a physician, I can tell you in the medical space, it's paternalistic and it's providers not necessarily having patient-centered care, from the outset. It's a term of art that has, come into being more recently. In the technology space, it's the same issue, right?
Sure.
And so that's really what we've been focused on in Chai.
Well, that's really helpful. And I'm thinking it might be helpful to this group. And I know Prevent Blindness and others that are on the call today have been aware of Chai. And actually, we've got some patients from this community that have stepped forward and said they're ready when we're ready to start to participate in the process. Maybe you could just describe kind of the structure of Chai, because I know there's kind of 4 different phases or areas of activity. And then I'll want to get into some of the ways in which we address some of those questions that the patient community has had, but maybe just give us a little sense of what Chai's structure might be, so we can picture our points of entry.
Yeah. So if at a high level, Randy, Chai is about that mission, enabling AI that's going to serve all of us. There are 4 areas of focus, as you mentioned. So the first is, all right, we need to develop this technical definition that we can all agree to. What is the consensus description of what good, responsible, trustworthy AI looks like for a developer, for a doctor and patient using it, for an AI governance committee that's maintaining it over time? And so we have a bunch of working groups that we've launched that are doing that. And we're going to launch a number of working groups. We've launched 5 working groups right now. And one of the ones that I'll call out, we have a direct to patient as consumer working group where, as I'm sure everyone can appreciate, many folks have different kinds of electronic devices where you can access the internet, and through some of those applications and websites, you're engaging in AI directly. It's not mediated by a provider. It's AI right in front of you, and use cases like that, we are developing the technical consensus about what are the good best practices. In addition to developing best practices, we're also developing, okay, if we have a definition of good, how do we measure a model's alignment or misalignment to that definition? How do we measure bias? How do we think about fairness? These are terms that we urgently need to have technical specificity on how to measure them. so that we can have more objective ways of evaluating if a model's fair or not.
Mm-hmm.
It's one thing to talk about it at a 50,000-foot level in a policy meeting. It's an altogether another thing to say, what is the actual math that enables us to have an objective perspective on them? So those are the working groups. The second big area of focus is really around enabling independent, trustworthy evaluation of models.
Mm-hmm.
In every other sector of our society, Randy, of consequence, where a person's life might be at stake. Think of things like the automotive industry with car crash kits, the aerospace industry with all of the inspections that airplanes should have before they fly, or consumer electrical devices
Mm-hmm.
and the rigor of evaluation that goes into a lamp before you put it into your infant son's bedroom out of concern you don't want it to start a fire. Every sector has entities that are independent from the manufacturers that test and evaluate whatever the device is, the machine is, for safety, for efficacy. We don't have that in health AI. And just as we talked about from the beginning, the pace of the development and the capabilities, particularly in the generative AI space, that these models are having and demonstrating is breathtaking. We urgently need to be able to have consensus definitions on what good looks like, how to measure it, and then empower entities that can be trustworthy, conflict of interest free, and that have the capabilities, namely testing data, to be able to independently issue an evaluation. Yes, this model meets those definitions. No, it doesn't. Yes, this model is safe to be practiced on all people, or no, it's not. It performs really poorly on these populations of people. So that second big thing is this quality assurance lab that we're looking to support and build within CHI. There's about 30 or so labs that have already raised their hand within our community and said, we want to be one of those labs to be able to do that. The third space is in our registry. And this is where we are looking to intentionally and directly put all of those report cards that come out of these labs, the evaluation reports that these labs are going to be issuing, are going to be available and publicly available for society, for patients, for everyone to be able to be more informed. Again, back to the concept, nothing about us without us. You need to know where the models are deployed and how they're performing to be able to have even the beginnings of a conversation with a provider or a technology company to help, drive improvements, to have the kind of consent that patients should have about models that are used on them by a health system. And so what we intend to do in CHI is all of our quality assurance labs prepared to be able to submit their evaluation reports to a public registry where patients, consumers, where doctors as well, and technology vendors, our elected officials, will be able to have access to these evaluation reports. The fourth big thing is educational content. We urgently need to be able to create the kind of curriculum that enables people to have the kinds of conversations we need to have that allow us to think critically, evaluate critically AI. We need to be able to educate patients, doctors, nurses on what responsible AI means so that when they're confronted with a specific potential use of AI, they can ask the question, if I'm the patient, do I want that model used on me? And how should I think about it? And so those are the four areas. So working groups, quality assurance labs, the registry, and the education. And in every one of those, we're partnering, Randy, with you and your organization to make sure that patient centricity is front and center in everything that we're doing.
Well, Brian, I really appreciate you walking us through that because I think it gives the audience here confidence that there are this kind of structures in place, some of which really came from thinking that goes back several years. I think the principles and the recommendations, this has already been a journey that's had a lot of input and a lot of good thinking. And now that structure is starting to actually engage patients and other stakeholders. And in a relatively short time, really seeing all of those parts, including the assurance labs and others, really starting to kick in. We have a question in the chat, and it's kind of focused on something that we've talked about want to come back to some of the areas of working group focus, because I think that'll be of interest to this crowd. But what you just talked about speaks to a question that was submitted, is how as we start to envision these innovations through AI that might start to be more visible or more influential in patient care, how do we address those fears or concerns that patients may naturally have? And of course, you as a physician will be thinking about how are physicians themselves interacting with AI, and then how are they sharing with patients what it is about their care, their recommendations that may be influenced or augmented by AI. But, in some cases, I don't know if it's a lack of information or exposure that might create a stigma or just a sense of caution. How do you think we're going to navigate that so that people really are kind of all in to at least look at the potential and then help us avoid any pitfalls that could occur?
So fundamentally, we have a trust problem. And the reason there are good reasons, as I said earlier, why we have a trust problem with AI. If you ask me, I'd say one of the biggest leading reasons why fundamentally we have a problem is the lack of transparency.
Mm-hmm.
As a doctor, I went through years of education, certification tests, board certifications, continuing medical education. All of these things oftentimes are transparently available to a patient in the community. And over decades, centuries, frankly, doctors have become, trusted by our patients because of things like the Hippocratic Oath that we take. AI certainly hasn't been around for centuries, but nor do we have that kind of understood rigor around being able to articulate how did it get to be so smart, conceivably smart? How did it learn the thing that it's doing now? Doctors, I think, as you mentioned, even have this problem, right? As a physician, oftentimes with the tools that I might have on my electronic health record, I don't know how that model was trained. I can't tell you how it performs specifically against patients like the one in front of me that I might be prompted to use that tool on. And so part of the problem, just as you described, Randy, is transparency. And so if we want to enable the kind of trust, it needs to start with empowering patients and providers and nurses to have the transparency that they need, that they should demand around how these models were built and how these models perform. Now, part of that answer fundamentally is going to come from the model developers. How are they built? What were the data sets that they were trained on? This should be a question that every patient should be able to ask their provider, and the provider should be able to answer. How was that model trained? Was it trained on patients like me? The patient community on the call today should have the right to, and should feel comfortable asking that question. The provider should have the information to be able to answer that. Oftentimes, candidly, we don't. So if you ask that question right now, probably the answer you get is, I don't know. And that's a big problem. And so the other part of what we're working on is building out these nutrition labels. In essence, when you go to a store and you look at a cereal box or a product, you get a nutrition label, what it's made out of. How healthy is it? How many carbohydrates, how many sugars, how many trans fats and saturated fats? All these things have definitions. We know what they are, and we can test for them. We're doing that with model cards or nutrition labels for AI so that a provider or a health system organization can say, that's a good question. If you get one like that from the patient, and then be able to answer it with the kind of insight provided by the transparency the model developer is giving and the independent evaluator is giving, right? Because I would argue, not appropriate to fully rely on a model developer to tell you how safe a model is. There's an obvious conflict of interest there. And so to avoid that, we need these kinds of entities that are doing the independent evaluations of models. And so it's really a multi-step process that, starts with transparency, both for providers and patients, ensures that there's space for the patient community to feel they have the right and the opportunity to have those conversations. How is this model trained? Was it trained on people like me? What are the test results of this model on someone like me? And then be able to have conversations with the providers that hopefully have the information to be able to have that conversation with their patient.
That is really helpful to have you frame that, so simply. And I know you'll give us some suggestions later in this program about how we can be involved. But I'm hearing a role for our patient organizations, patients themselves, to really be able to use the language that you just used and have a sense of confidence in saying, how was this model trained, and what does this mean for me? And I think even asking, is the healthcare system around me as it relates to my visit today or my treatment or intervention include AI models? And if so, talk to me about those. But I see a role for us as really trying to develop that level of literacy and confidence in putting some of these questions forward and then working throughout the system to try to help it respond. One of the things that we've talked about, and I think it's a natural, step from what you just shared, is the ethical concerns. And I know this has been a topic that has always been up front and center at any conversation around CHI or the AI conversation, is what are the ethics of how, these AI models evolve? And I'm thinking about things like bias, things like privacy or security, and where does the individual's concerns begin and end, and when is it for the greater good of population health? Can you just comment on that ethical lens?
It is so hugely important. Um, when we think about ethics, we oftentimes think about in the context of human decision making and ethical considerations, end of life care, decisions that providers and patients often are engaged in, you know, intentionally meaningful, critical conversations around.
Hmm.
It's no different in the AI space, particularly with the kinds of uses that AI has. If AI is going to be used, and it will be, it's already being researched, to be used in cases that have pretty significant impact on the patient's quality of life, longevity of life, the kinds of care that's delivered. Um, Ethical considerations need to be front and center. And you identified several of them. The first one, the one that certainly concerns me the most, is bias.
Hmm.
Uh, there is a quote that you and I have talked about from the Atlantic and Young, with digital health technologies oftentimes being most used, most advantageously used on the penthouses of society, people that are
Right.
well educated, affluent. And part of the reason why that's a significant issue in AI is because the data sets that are available, oftentimes from, I think, very well intentioned academic medical centers, oftentimes that are in highly urban central locations, they service highly educated, affluent, urban people, not a diverse population set. And the kinds of bias that you find in models that are trained on those kinds of data is pretty significant. I'll give you an example. A health system partnered with a technology vendor to train a model in the cardiovascular space to detect heart attacks with EKGs. The EKGs are the wave forms that you see that kind of measure the health of your heart. And the technology vendor trained this model, and they were about to submit it to the FDA with the indication that it would identify heart attacks for all middle-aged people, because that's what they thought they had. They trained it on the data from this AMC. Um, what they found when they actually tested it with more rigor was a level of bias that the model performed exceptionally well on Caucasian, affluent, urban individuals, where the model was trained on. But when you looked at a different data set, a more African American data set, a more rural Appalachia data set, the accuracy of the model significantly was degraded. And so you uncover these kinds of biases in these models. And if we want to have, again, AI that's going to serve all of us, we need to have a level of rigor and intentionality in how we instruct and tune these models to clearly articulate the limitations. In the case of this example, this model should be used on these kinds of people, and the limitations. This model should not be used in inner city African American population, rural Appalachian populations. And so uncovering the bias and ensuring that individuals understand both the indications and the limitations are critical. The other two ones you also mentioned, privacy, security. As models become more and more capable, one of the growing concerns many of us have in this space is this idea of re-identification.
Mm-hmm.
The more that you have a data set and you strip out identifying features or potentially identifying features of any one individual, you lose a level of richness in the data set, the potential features that could correlate to a risk for a particular outcome. So if all you're left with is just a few features, you have a data set that might not be able to develop many correlations because there's just not many features in that data set. And so it's this balance of creating a feature-rich data set that allows a model to identify potential causal inferences that could lead to a bad clinical outcome, with the risk that because you have all those features, that model could potentially re-identify individuals. And as we get to in the more generative AI space, where you have models that this term called hacking, essentially where you have a model and you can put in certain kinds of prompts and lead a model, frontier model, down a path to potentially re-identify different kinds of people, becomes a greater risk. And there's not a straightforward answer in terms of what's the right way forward and what's the wrong way forward. But I know for a fact that it involves ensuring patients are informed of how their data is being used, have the right to consent to their data being used, and ensuring that there are the appropriate kinds of safeguards against re-identification. Right now, in CHI, I think our belief is that we don't have enough of the first two, right, to consent and to be informed. We're working on the third, the safeguards, the technical approaches to ensure data is de-identified enough so you can't possibly have re-identification. But privacy is a big equity that involves and starts with ensuring that patients are involved as part of the conversation.
Well,
security is another big one too. But I'm sorry, go ahead.
Yeah,
No.
I think these are such compelling issues, and they're top of mind because as I interact with patients, the patient community, people want to see innovation occur. They want to see research lead to better interventions for them to manage their own health and contribute to the greater good. So there is that desire to contribute. Some of our patient organizations have registries that have decades of data that position, patients to be participants and seen within these data sets. So it's encouraging to hear you say that you are looking at, security and privacy and control, that would be a component I think that'll be of great interest to patients. Before we start to wind down, though, if I could ask you to do just a couple of things, then we'll turn things back over to Jeff. But one, maybe just touch on the areas I know that CHI is going to address through these working groups, because I think for the patient community, they're going to see things that are very relevant to their health and their patient experience, things like clinical decision making or, the way in which research might evolve. And then the other piece is, what is that call to action? You've touched on a lot of things that could be, it looks to me like opportunities for patients and their patient organizations to jump in. If you could just issue a call to action before we close, that would be terrific.
Thanks, Randy. Well, so it's been great partnering with you and Jeff and the team already on the 5 working groups that we've launched. And so these working groups initially are focused on a very high level way of describing the best practices for predictive AI and for generative AI, and then what those metrics are in each of those, predictive AI and generative AI, and how we measure a model's performance and alignment to good responsible AI. And then I mentioned the 5th working group being about direct patient, direct consumer working group. In each one of those, partnering with you, we have working group members that are patient community advocates that are helping to ensure patient voices are centered to all of those. We're going to be launching a whole bunch of working groups later on in the fall that dig really deep, moving from that broad set of kind of what does good responsible AI look like to saying, okay, there are a set of use cases. You mentioned one of them, clinical decision support, AI being used, between a provider and a doctor, or how AI is used in clinical research, or how AI is used in public health, or how AI is being used in medical device manufacturing, which is, I think, really important for this community because so many of the devices that an ophthalmologist uses that retinal scanners have involve things like computer vision algorithms that are embedded into or part of the medical device that captures the image. And what are the good best practices in those spaces? In each one of those working groups, one call to action is to work to be part of those working or to consider to be part of those working groups. We need folks' voices. They haven't launched yet. And so I think working through your office, Randy, and your team to consider nominating folks to be part of those is going to be really important. The next step, the next call to action is so the output of these working groups. We recently published a big document, the Assurance Standards Guide and its companion checklist. It took over 8 months. 120 people, 110 people went into developing this. It wasn't the whole CHI community. It certainly wasn't society. We need people's feedback. So another call to action is there's, yes, a 120-page document. I don't expect folks to read all of that. There's an executive summary that's 10 or 14 pages. We want people's feedback. If you go to our website, there's a form that you can link to. You can read the executive summary. We desperately want folks to offer their feedback to ensure that, again, we're building AI that's going to serve all of us. We need to include everyone's voice. And so we want the public's comment. We have a 60-day period. We're going to take all those comments and we're going to meaningfully respond to them and issue then a final first draft or final first version later on this year. The same thing is going to happen with each of those working groups.
Great.
So we are looking for folks to offer their feedback as the work process.
That is so helpful. And I know you've been generous with your time as well as your team. The Health Council is sponsoring an open session once a month, and you've been providing updates there. It's called our AI Affinity Group, open to anyone who's on this call, anyone part of the National Health Council leadership. Will continue to be a dissemination point for those opportunities to engage or to react to what you're doing. But Brian, I can't thank you enough for how amazing it is to work with you, to work with your team, to see this vision becoming real and something that's so critically important to our community. So I know you're going to be staying on to answer some questions and things in the live chat. Why don't I turn things back over to Jeff, and I'll look forward to our ongoing collaboration from this point forward. Thank you.
Thanks, Randy.
Well, thanks so much, Randy and Brian. This has been a terrific conversation, and I really appreciate both of you being leaders and making sure that advances in AI and health always move forward with the patient at the center.